Good morning to one and all. I am Dr. Shyamala, Senior Resident in the Department of Anesthesiology, SLIMS. Today we are going to discuss about transfusion therapy. So we know that we are using blood products for a transfusion. Blood products are administered as a therapeutic agent in the perioperative management. The use of blood products, which includes red blood cells, fresh frozen plasma, platelets, or cryopreserved, continues to be defined in surgical conditions. In some countries, even if there are purified protein concentrates like fibrinogen and prothrombin concentrate complexes are available instead of transfusion, it is used instead of transfusion factors. A decision to transfuse the blood products requires multiple clinical considerations, which includes risk factors, comorbidities of the patient, hemodynamic stability of the patient, and the rate of bleeding, especially in case of hemorrhagic shock, which is a common perioperative emergency we are used to see day-to-day life. Despite our extensive use of transfusion in the perioperative settings, they have been associated with a complex series of adverse events, which includes infection, stroke, renal failure, multi-organ failure, and there is increased hospital and intensive care stay. The American Society of Anesthesiologists established the Task Force on Blood Component Therapy to develop evidence-based guidelines for transfusing these blood products, and which includes the risk of bleeding in surgical patients determined by extent and type of the surgery, the capacity to control the bleeding, the expected range of bleeding, and the outcomes of uncontrolled bleeding. RBC transfusion should not be dictated by a single hemoglobin concentration of the patient or a single hemoglobin trigger, but instead it should be based on each individual patient's risk of developing complications of inadequate oxygenation. The indication for autologous transfusion may be more liberal when compared to the allogeneic transfusion. Prophylactic platelet transfusion is ineffective when thrombocytopenia is due to platelet destruction. Fresh frozen plasma is needed for urgent reversal of warfarin therapy or correction of unknown coagulation factor deficiencies or correction of microvascular bleeding whenever the prothrombin and partial thromboplastin time is more than 1.5 times the normal limit. Cryopreservation should be considered for the patients with von Willebrand's disease who are unresponsive to desmopressin or with continued bleeding, or with patients having fibrinogen less than 800 to 1000 milligram per deciliter. We all know that we are using whole blood for transfusion as well as the individual blood components for transfusion. Now we can see how much of whole blood we can use for transfusion. Whole blood is an unseparated blood containing an anticoagulant preservative solution. The indication for whole blood transfusion is for patients who need both increased oxygen carrying capacity as well as the restoration of blood volume, which will be lost in the trauma, and when there is no time to prepare or obtain specific blood components. And it is also indicated when the blood loss is more than 25%, we can use whole blood for transfusion. The composition, each unit contains about 450 ml of donor blood and 50 ml of anticoagulant preservative solution used in it, and it can be stored at the temperature of 2 to 6 degrees Celsius. It contains hemoglobin approximately 12 gram per ml and a hematocrit of 35 to 45%. It does not contain functional platelets. The transfusion should be started within 30 minutes of removal from the refrigerator and should be completed within 4 hours of starting the blood, because the changes in the composition may occur due to red cell metabolism. Coming to packed RBCs, it is indicated when the blood loss is less than 25% of the normal value, like acute ongoing hemorrhage or severe symptomatic anemia patients. It is supplied in usually 250 ml of the bloods and contain RBC of about 80% and hematocrit of 50 to 70%. They are stored in the SAGM solution, that is cyanide glucose mannitol solution, to increase their shelf life up to 5 weeks. It can be stored at the temperature of 2 to 6 degrees Celsius. The typical dose is 2 units per 2 units or 5 ml, 15 ml per kilogram of the patient. It should be transfused over 2 to 3 hours. If the patient cannot tolerate the volume over a maximum of 4 hours, it may be necessary for the blood bank to deliver a unit into a smaller volumes, providing proper refrigeration of remaining blood is available. 1 unit should raise the hemoglobin approximately by 1% and hematocrit by 30%. There are some special processing of RBCs which can be used for the patients like glucosate reduced RBCs, irradiated packed RBCs, and washed packed red blood cells. Glucosate reduced packed red blood cells can be used because it can decrease the non-hemolytic separate reactions, decrease the risk of virus transmission to prevent the sensitization in patient for bone marrow transplantation. Irradiated RBC should be considered in patients with renal transplant patients or neonates and who are having immunocompromised stage. Washed packed RBCs decreases the risk of anaphylaxis in IgA deficient patients. It decreases the risk of reaction in patients with recurrent or severe allergic reaction to blood products. One important aspect of adverse events associated with RBC transfusion relates to the age of the RBCs transfused and the changes that can occur in the stored RBC as they ages, which is called as storage lesions. And studies have suggested that RBC when stored for longer periods, that is more than 14 to 21 days, may lead to adverse effects. The mechanisms include senescent RBC fragments, causes the impairment of nitric oxide production and increased nitric oxide scavenging. Together with reduced nitric oxide production by dysfunctional endothelial cells. The mechanism for the adverse events like RBCs can develop a complex series of biochemical and metabolic changes during storage in the blood bank, which include depletion of ATP and of 2,3-diphosphoglycerate, and there will be membrane phospholipid vesiculation and shedding, protein oxidation, and lipid peroxidation of the cell membranes. As the blood ages, the RBCs undergo shape changes with increased fragility, which may impact the microcirculatory flow. Because of the increased red blood cell endothelial cell interactions, the bioactive lipids and other substances which are released may initiate an inflammatory response, which may lead to TRALI, that is transfusion-related acute lung injury. These complex changes may also decrease the oxygen delivery and increase the hemolysis. When free hemoglobin is released from the RBC, it binds to the nitric oxide and leads to the nitric oxide scavenging, which ultimately causes endothelial dysfunction and additional inflammatory events lead to the generation of oxygen-free radicals. Fresh frozen plasma, it is prepared at the time and the blood is supplied from the donor. If the plasma is frozen within 8 hours of collection, and it is known as frozen plasma, from which we can also isolate cryoprecipitate. Thawed plasma or FB24 is the one which can be stored up to 5 days before administration. Fresh frozen plasma is usually stored at a temperature of -40 to -50 degrees Celsius with a shelf life of 2 years. Indication for effective transfusion is it can be used for the patients with clotting disorders like coagulation factor deficiencies, fibrinogen replacement, disseminated intravascular coagulation, liver disease, exchange transfusion, massive transfusion, and warfarin overcoagulation effect. It can also be used for patients who are actively bleeding with PT and APT value greater than 1.5 times the normal. It also used for treatment of thrombotic microangiopathies like transient thrombocytopenic purpura, hemolytic uremic syndrome, and HELP syndrome. It contains 1 unit of each coagulation factors and fibrinogen 2 mg per ml and plasma proteins. It requires ABO compatibility before transfusions. It is supplied in 200 to 250 ml of bags. Can be infused over a period of 30 to 60 minutes using a regular YSET or filtered tubing. The typical dose is 4 units for the patient or 10 to 15 ml per kilogram of the patient. It raises the most coagulation factor levels by approximately 20%. RBC, there are several special processing of RBC. We can also use solvent and detergent treated plasmas. Human pooled plasma that can be detergent or solvent treated is now commercially available. And these units are that frozen plasma are thawed, cooled, and filtered through a 1 micrometer pore membrane and then treated with the detergent or solvent reagents to inactivate the enveloped viruses. And these reagents can be removed by sequential oil and solid phase extraction procedures, which also remove the prions. After sterile filtrations, the product is filled into the blood bags, labeled, deep frozen, and stored at 4 degrees Celsius. Leukocyte antibodies are not detected in this plasma because the process dilutes the blood cell antibodies and soluble HLA antigens which are present in the product, thereby neutralizing the antibodies and reducing the risk of development of TRALI. Cryoprecipitate is the one which forms when the fresh frozen plasma is thawed slowly at 1 to 10 degrees Celsius, which is then again refrozen and stored. It contains about 150 to 200 milligram of fibrinogen, 80 to 100 units of factor 8, significant amounts of factor 13, bone membrane factor. Also include high molecular weight, multimers, and fibronectin. It is indicated for the patients who have the less fibrinogen levels like less than 1 gram per deciliter, factor 8 deficiency or factor 13 deficiency, bone membrane disease. Since it does not contain factor 5, it cannot be the sole replacement for disseminated intravascular coagulation. It may be associated with variety of factor deficiencies and thrombocytopenia. The transfusion rate is about 200 ml per hour infusion, increase at a rate of 10 to 15 ml per unit. The infusion should be completed by 6 hours of thawing. The typical dose is about 10 units per patient or 1 unit per 5 kg of the patient. It can raise the fibrinogen level by 75 milligram per deciliter. Platelets are usually used clinically, either a random platelet or single donor apheresis, and can be stored up to 5 days. The indication for platelet transfusion includes stable patients without evidence of bleeding or coagulopathy who have platelet less than 10 lakh per microliter, and can also be used for patients for prophylaxis of central venous catheterization with platelet count of less than 20,000 per microliter. Prophylaxis for invasive procedures such as lumbar puncture, neuraxial anesthesia, endoscopy with biopsy, or major non-neuroaxial surgery like with platelet count of less than 50,000 per microliter. It also be used for patients with the clinical evidence of bleeding or coagulopathy, including disseminated intravascular coagulation with platelet count of less than 50,000 per microliter. It is also used for patients undergoing massive transfusion with platelet count of 75 to 1 lakh per microliter, and patients having surgery at critical sites like eye or central nervous system with platelet count of 80,000 to 1 lakh per microliter. Microvascular bleeding attributed to platelet dysfunction such as uremia, liver disease, post-cardiopulmonary bypass can also be used. It contains about 3 to 6 or 3 to 6 per thousand. It can be supplied in 250 ml from single donor, 300 ml from two donors or random donors. The typical dose is about 1 unit or 5 ml per kilogram. It is administered as rapidly as tolerated, usually 4 units every 30 to 60 minutes. It can raise the platelet count by 50,000 per cubic millimeter. Purified protein concentrates include fibrinogen concentrate. It is used for patients with microvascular bleeding with hypofibronemia with DAC with fibronetin less than 150 milligram per deciliter, or patients with hemorrhage or massive transfusion with fibrinogen less than 180 to 200 milligram per deciliter. Prophylaxis is indicated in patients with hemophilia A or bone membrane disease if specific factors are unavailable or ineffective due to inhibitors. Can also be used for prophylaxis of patients with congenital dysfibromatosis. Prothrombin complex concentrates are recommended in guidelines as primary treatment for reversal in patients with life-threatening bleeding or increased INR patient when urgent reversal is required. It is also used for reversal of warfarin or vitamin K antagonists, including oral or intravenous vitamin K, human FFP, and the prothrombin concentrate, complex concentrates. Bone membrane factor, it is a human anti-hemophilic factor, is commercially available and indicated for treatment as well as prevention of bleeding in adult patients who are having hemophilia A. The other indications include treatment of spontaneous or trauma-induced bleeding episodes of patients' bone membrane factor disease, or patients' prevention of excessive bleeding during and after surgery. C1 esterase inhibitor concentrates. Hereditary angioedema is a life-threatening disease resulting from absence or genetic mutation of complement component inhibitor called the C1 esterase inhibitor. Although there are several variants, they share a common pathway following tissue injury, intubation, other inciting agents which can lead to unopposed activation of multiple inflammatory pathways and mediators including kallikrein and bradykinin release which increase the vascular permeability. Angioedema produces increased permeability of submucosal and subcutaneous capillaries and post-capillary venules, which lead to plasma extravasation and subsequent swelling of critical airways structures and also the systemic effects. Coming to blood component productions, now we can see the steps which are followed in blood component production. The first step is blood collection. Usually, the blood donors are carefully screened and tested, and the blood products are made in the specialized laboratories and other facilities. Regional blood centers collect and provide the most of the blood components for transfusion, and some hospitals directly collect the blood or platelets to augment their supply. The donor's vitals like pulse, blood pressure, and hemoglobin or hematocrit level should be checked. Phlebotomy is performed with validated antiseptic measures to reduce the risk of bacterial contamination in the blood bags. In whole blood donation, around 450 to 500 ml of the blood is collected into the citrate anticoagulant solution and then separated by centrifugation into various individual components of blood like RBCs, platelets, or plasma. Following blood collection, we should do the component processing and then we store the blood for further transfusion. Glucoreduction is done to remove the WBC from RBCs and platelet to reduce the risk of HLA alloimmunizations and also to reduce the febrile non-hemolytic transfusion reactions and the cytomegalovirus transmission in patients who require these precautions. Washing the cellular components with saline is mostly done to remove the plasma in patients with allergic transfusion reactions such as who are IgA deficient. It does not affect the antigens on the cells and does not remove enough WBCs which can prevent the graft versus host disease or HLA alloimmunization. Irradiation can be done to prevent the transfusion of graft versus host disease from directed donor units from the blood relatives. Or in patients with highly immunosuppressed stage, leukemia, lymphoma, hematopoietic stem cell transplant, congenital cellular immunodeficiencies, and purine analogs such as fludarabine. And these units are usually exposed to gamma radiation to damage the donor WBC DNA, which can prevent the cellular immune proliferative response to the recipient tissues. It is also performed with cesium-137 blood irradiators. So to summarize, packed RBCs are available in an average volume of 300 ml and can be stored at temperature of 1 to 6 degrees Celsius for 21 to 35 days or maximum up to 40 days with additive solution. Red blood cells frozen available in a 300 ml volume and it can be stored at temperature less than minus 65 degrees Celsius for a period of 10 years. The platelet whole blood derived, it contains 50 ml per bag. Our usual dose is 4 to 6 bags stored at a temperature of 20 to 24 degrees Celsius for 5 days. Apheresis platelets are supplied in 300 ml of bag stored at temperature of 20 to 24 degrees Celsius and be stored up to 5 days. Fresh frozen plasma is supplied in 250 ml of the bag at the temperature less than minus 18 degrees Celsius for a period of 1 year, and if it is stored less than minus 65 degrees Celsius, can be stored up to a period of 7 years. And frozen plasma within 24 hours, it is supplied in a 250 ml bag and can be stored at less than 118 degrees Celsius for a period of 1 year. Cryoprecipitate is 15 ml per bag. Our usual dose is about 4 to 6 bags and can be stored at temperature less than minus 18 degrees Celsius for a period of 1 year. After component processing, we should inactivate the pathogens, and these techniques have been developed to inactivate microbial pathogens in the blood components, and the techniques may vary by blood component. Cell-free plasma, either in pools or as individuals, can be treated with membrane disrupting for solvent detergent treatment for envelop the viruses. When methylene blue, sterile, and riboflavin is added to the blood bag, they bind to the nucleic acids. Then photo inactivation is performed with agent-specific wavelengths of light. Then cross-linking of DNA and RNA to prevent the microbial function. Coming to the various solutions used for storage of blood, first one is ACD solution, and it contains trisodium citrate, citric acid, and dextrose and water with pH of 5.5. The usual ml of ACD added to the blood is around 67.5 ml with 420 to 450 ml of blood. It can be stored up to 120 days only. CPDA solution. This is an anticoagulant in which the blood is stored at 1 to 6 degrees Celsius. It contains citrate, which can act by binding calcium, phosphate, which is acts as a buffer, dextrose, which is an energy source for red cell, and adenine, it helps RBCs to synthesize the ATPs. The exchange storage time from 21 to 35 days, and 63 ml of CPDA is added with 450 ml of whole blood. And the CPTA plus ASR1, it can increase the shelf life up to 42 days. It contains glucose, adenine, mannitol, and sodium chloride. CPDA plus Nutrizell, it can also extend the shelf life up to 42 days. It contains glucose, adenine, citrate, phosphate, and sodium chloride. After that, we should perform compatibility testing before transfusions. It includes ABU as well as RHG typing and antibody screen for immunoglobulin G for non-ABU RBC antibodies and then RBC cross-match. The RBC must be ABU compatible to avoid the intravascular hemolysis, and RHG negative patients should receive B negative RBCs to avoid anti-D autoimmunization. The other RH, Kelly, and some other non-APO antibodies can also neutralize the transfused RBCs. About 1% of all patients and 5 to 20% of heavily transfused patients have such antibodies. If no antibodies are present, the cross match may be electronic. Then the RBCs are selected by lab computer to label it as ABU and RHD compatible. But if hemolytic antibodies are detected, the RBC means negative for incompatible antigens, and a serologic cross match of the patient plasma versus donor's RBC need to be performed to compare the compatibility. Cross match usually done at 3 phases: immediate phase, incubation phase, and anti-globulin phase. In immediate phase, it is done at room temperature to check the antibodies against ABO typing errors. It takes about 1 to 5 minutes. It can detect ABO, MN, P, and UE system incompatibilities. Incubation phase done at 37 degrees Celsius with albumin for 45 seconds or low iodine stem saline for 10 to 20 degrees Celsius. It helps in detection of incomplete antibodies. Anti-globulin phase, addition of anti-globulin sera to the incubated test tubes. Anti-human antibodies present in the sera or attaches to the antibody globulin on RBCs can cause agglutinations. It detects most of the incomplete antibodies in the RH, KEL, and FICOs. Coons test is used to detect circulating antibodies against RBCs. There are 2 types of Coons tests: indirect and direct Coons test. Direct Coons test is to perform to detect the anti-D antibody, whereas indirect Coons test is used to perform to detect antibodies against RBCs. In case of emergency transfusions where we are not able to cross-match the blood very quickly, we can use these type of blood for transfusion, like dye-specific and partially cross-matched blood. It takes about 1 to 5 minutes. Patient serum is added with the donor's RBC and the room temperature. You can centrifuge it and look under the microscope for agglutination. If agglutination is found, it is incompatible. If there is no agglutination, you can use for patients. Type-specific uncrossed matched blood, relatively safe and do not used indiscriminately. Caution in patients who are pregnant before or have earlier transfusion reactions. Type O RH blood, more than 2 units are transfused and do not give type-specific blood. If given, causes major hemolysis of donor RBCs. There are various blood transfusion, like autologous blood transfusion, which means the reinfusion of blood or blood products taken from the same patient. There are various techniques like preoperative blood donation, acute normovolemic hemodilution, intraoperative autologous transfusion, and postoperative blood salvage techniques. Coming to the advantages of autologous blood transfusion is it can avoid many complications associated with allergic transfusion, like acute hemolytic reactions, allergic and febrile reactions, and transmission of diseases. It can also avoid the immunosuppressive effects of allogenic transfusions. Patients with rare blood group are particularly benefited with this technique. It allows the availability of fresh whole blood for transfusion. Donor selection for all these type of techniques can be considered before any elective surgical procedures where there is a significant blood loss is expected. Any patient with adequate hemoglobin or 11 gram per deciliter, adolescents or children below 10 years of age, and elderly can also be a candidate and can safely donate the blood. Obstetric patients, there is no adverse effects for mother and baby are reported. A history of hepatitis B and AIDS is not a contraindication for autologous blood transfusion. Preoperative blood donation, it usually begins 4 to 5 weeks before the proposed surgery, depending upon the number of units required. A leapfrog technique is used. Usually 1 donation per week. In 5 weeks, we can have at least 5 units of blood, maximum 1 transfusion per 3 days. To prevent the anemia due to donations, iron tablets are usually prescribed. There is no special complications for pre-donations. Time interval between the last donation and the surgery should be more than 72 hours. It can be separately labeled as autologous. You can do embryo and RH typing. Screening for hepatitis and AIDS are not mandatory since it is autologous. No cross-matching is required. If CPDA1 is used for storage, the blood can be stored up to 35 days. And separation into plasma and RBC increases the shelf life up to 42 days. If more storing is required, the RBCs can be frozen and stored. Contraindications for preoperative blood donation is evidence of infection or risk of bacteremia, schedule the surgery to correct aortic stenosis, unstable angina, patient with active seizure disorder, myocardial infection, or cerebrovascular accidents, patient with cyanotic heart disease, significant cardiac or pulmonary disease, bleeding diagnosis, and uncontrolled hypertension. The complications for preoperative blood donation is volume overload, sepsis, and transfusion of wrong blood due to clerical error. The other technique is acute normovolemic hemodilution. It refers to the removal of blood from the patient immediately before or just after the induction of anesthesia and replacement with fluid. No pre-donation is done with this technique, and the lost volume is replaced by crystalloids if 1:3 or electrolytes in the ratio of 1:1. Collected blood can be stored at room temperature for up to 4 hours and can be stored at 1 to 6 degrees Celsius for 24 hours. And the blood can be reinfused in the reverse order of collection. The first unit, which has the high hematocrit and low clotting factor, should be administered last. Withdrawal of whole blood and replacement with crystalloids and colloids will lead to the sudden drop in the hematocrit, arterial oxygen content, and decreased blood viscosity, which can increase the cardiac output and decrease peripheral resistance, so that oxygen delivery is not affected in these patients. Heart rate, blood pressure, and the central venous pressures remains unchanged. The advantages: it is simple and less expensive. It provides fresh whole blood for transfusion. No biochemical alterations associated with storage. And removed blood can be stored at room temperature, so there is no chance of hypothermia. The RBC loss during the surgery is less because it is diluted with fluid. Hemodilution decreases the blood viscosity, which improves the tissue coefficient. It can also be used for emergency surgeries. Indication is cardiac bypass surgery. The contraindications for this technique is patients having anemia with hemoglobin less than 11 gram and hematocrit less than 33%, and those who have severe coronary artery disease, carotid artery disease, severe pulmonary dysfunction, and severe renal dysfunction. The complications of this technique is myocardial ischemia and cerebral hypoxia. Intraoperative and postoperative blood salvaging technique with the use of special equipments. The blood is collected from the operative field and the draining site, and this recovered blood is mixed with anticoagulant with the reservoir and a filter. Then the filtered blood is washed with saline. The suspended RBCs in the saline are then pumped into the reinfusion bag. Most of the WBC, platelets, and clotting factor cell fragments and RBCs are eliminated because of this filtration technique. Characteristics of processed blood: the hematocrit of processed blood is about 50 to 70% and can be varied by altering the processing parameters. Oxygen transport properties and survival of RBCs are equal or almost superior to the stored allogeneic trend. It has high 2,3 diphosphoglycerate level, and the pH is alkaline. Potassium and sodium levels are normal in this type of blood. Indication is patients which is more than 20% of blood loss is expected, and patients with rare blood group, elective and emergency surgeries like cardiovascular surgery, liver transplantation, neurosurgery, orthopedic surgeries, gynecological surgeries, traumatic penetrating injuries with the ruptured spleen or liver, and ruptured aneurysm. The complications with these techniques are air embolism, fat embolism, sepsis, renal dysfunction due to free hemoglobin, and fragmented RBCs. Presence of tumor cells in the operative field is considered as a relative contraindication. Coming to the complications of blood transfusion, we can divide the complications into infectious and non-infectious. Again, non-infectious into immune-mediated and non-immune-mediated. Infectious risk: the risk of transmission of HIV is about 1 per 230,000 with a window period of 7 to 10 days, and hepatitis C virus is about 1 per 180,000 with a window period of 7 to 10 days. Human T leukocyte virus 1 and 2, the incidence is about 129,93,000 with 51 days, and hepatitis B virus is about 1 per 280 to 35 3,52,000 with a 38-day window period. The emerging infections like West Nile virus, Creutzfeldt Jakob disease, parvovirus, B19, dengue virus, and rabies disease can also be transmitted via blood transfusion. Bacterial contamination, the overall incidence is about 1 per 30,000 with packed RBCs, and platelet is about 1 and platelet with 1 per 3,000. Non-infectious is coming to non-immune mediated transfusion reaction, febrile non-hemolytic transfusion reaction. It presents within 4 hours of transfusion with increase in temperature of 1 to 2 degrees Celsius and may be associated with chills, dryness, anxiety, and headache. These are usually self-limited and can be prevented or treated with anti-inflammatory or antipyretic drugs. The pathophysiology involves recipient allowed immunization to HLA antigen from the donor WBCs and which lead to the release of derived cytokines during the blood storage product. Allergic reactions are usually minor and relatively common type of transfusion reaction occur in about 1 to 3%. The symptoms include urticaria, hives with or without pruritus or angioedema. The specific cause for allergic reaction is unclear, but mostly involves an immune response to recipient WBC antigens or transferred plasma proteins. Major allergic reactions are present as anaphylactoid or anaphylactic reactions with hemodynamic instability, bronchospasm, rash, flushing, or angioedema. It is very rare with the incidence of 1 in 50,000 transfusions, and it is due to recipient typically patients who are IgA deficient with anti-IgA antibodies. They can develop immediate immune response to transfused plasma proteins or cellular antigen. Acute hemolytic transfusion reactions occurs with transfusion of incompatible blood products with pre-existing IgM or IgG antibodies in recipients which forms the complex with the donor RBC antigens. Classically, these reactions result from ABO incompatibility secondary to native anti-A or anti-B IgM. The other RBC antigens such as Duffy causing acute hemolytic reactions with patients of transfusion exposure or alloimmunization. Rarely, the transfusion of incompatible plasma type O or whole blood to the patient with type A and AB blood has resulted in this reaction as well. It occurs secondary to IgM-mediated antibody antigen complexes, which can activate complement, resulting in intravascular and extravascular hemolysis in spleen as well as liver. The release of various substances like bradykinin, which can cause fever, hypotension, hemodynamic instability, whereas systemic release from the master cell can lead to bronchospasm and urticaria, as well as the symptom of dyspnea, flushing, and severe anxiety. Hemolysis results in the release of free hemoglobin, which may be bound by haptoglobin and plasma proteins, which is usually need to be eliminated by kidneys, and these proteins were unavailable. Severe hemolysis can lead to renal failure, disseminated intravascular coagulation, and death. General anesthesia can answer several of the presenting symptoms of this reaction. Diagnosis is with free hemoglobin, low haptoglobin, or bilirubin increases in the plasma serum level, the positive wound states, and hematuria. Treatment is usually supportive for hemodynamic instability and microvascular bleeding, maintenance of adequate urine output to avoid renal failure associated with hemoglobinuria. Anemia can be profound as the immediate hemolysis can destroy over 200 ml of blood per hour. Delayed hemolytic transfusion reactions result from passive transfusion of RBC antibodies to native antigens, more commonly the allo antibodies in the recipient to minor RBC antigens. Generally present about 3 to 10 days after the transfusion of compatible blood. The recipient has IgG and allo antibodies to the particular RBC antigens and mount an amnestic immune response. Symptoms is usually milder and rarely result in major morbidity and mortality. Patients experience mild fever and possibly rash with laboratory and clinical evidence of hemolysis such as jaundice, hemoglobinuria, low haptoglobin, positive wound tests, and decreased hemoglobin levels. Symptoms are generally self-limited and can be treated symptomatically with hydration to promote the renal tubules during hemolysis. Transfusion-related immunomodulation, it results from the multifactorial pathophysiologies that implicates transfused WBC, donor plasma, HLA class 1 peptides, cytokines, and immune mediators. Several experts propose their two-insult model. Presumably, most patients requiring blood products are suffering from the preconditions which acts as the priming for both the immune system as well as the vascular endothelium. And this constitutes the first insult and causes active neutrophils to occur for the vascular endothelial cells. and become hypersensitive to the blood-borne immune mediators. The second impulse occurs with the inclusion of the blood products which contains WBC with the HLA class 1 antigens as well as soluble immune response modifiers in the form of cytokines, complement factors, and breakdown product of lipid membranes. And this demonstrated decrease in T cell responsiveness and inhibition of monocyte function after the transfusion of RBCs. Alloimmunization refers to the induction of the immune response to the allogenic antigen exposure, and this process occurs occasionally through the pregnancy, but majority results from the transfusion of blood globules containing immunogenic antigen on the surface of the RBCs. Approximately IgG-mediated humoral immunity to foreign products, and it does not result in the RBC destruction until the second antigen exposure occurs. The incidence is estimated between 4.4 to 10.5% from it is especially evident for patients who require the frequent platelet transfusions. Platelet carries significant level of multiple human platelet antigens and other polymorphins which can result in the destruction of transfused platelets and the refractory thrombocytopenia. Transfusion-related acute lung injuries involves low-pressure pulmonary edema secondary to the neutrophil activation and sequestration in the lungs. It results in an endothelial injury and capillary leakage of proteinaceous fluid in the interstitium of intra-alveolar spaces. Antibodies forms in the donor plasma after alloimmunization from pregnancy, prior transfusion, and prior transplantations. Once the antibodies are transfused into the recipients, and they form a complex agent on the monocytes and thereby activating the neutrophils to facilitate aggregation and release of the cytotoxic mediators. Subsequently, endothelial lining in the lung is damaged. The second proposed mechanism is two-bed model as previously explained. Stored blood components are accumulated lipid degradation products that function to activate the neutrophil primed and sequestered in the endothelial vascular lining of nerve tissues. Patients with highest incidence of TRALI often suffer from the pre-existing pro-inflammatory states such as active infection, trauma, surgery, or multiple transfusions. Acute illness causes immune system to be hyperactive with neutrophils poised on the microvascular endothelium. The transfusion of the stored blood products and associated reactive lipid particles mark the second hit and activate the priming neutrophils to result in the destruction of capillary lining of the lung microvasculature. The management usually focus on the supportive measures to limit the lung injury as well as optimize the oxygenations, which includes maximize the positive end expiratory pressures, avoiding volume overload, and using low tidal volume stages. Transfusion-associated graft versus host disease occurs when the donor lymphocytes engraft in the recipient and attack host cells they recognize as the foreign. It includes those who are compromised from the stem cell membranes, B-cell malignancies, acute lymphocytic leukemia, and those with Hodgkin disease or congenital immunodeficiency syndrome. Immunocompetent patients are also at risk when they are transfused with direct donations from blood relations. It classically presents between 4 to 21 days after the transfusions. Symptoms affect the skin, hepatic system, digestive system, hematopoietic organ systems, causing fever, rash, liver dysfunction, diarrhea, and pancytopenia. Post-transfusion purpura is defined as the severe thrombocytopenia with purpuric rash occurs over 5 to 10 days after the transfusions. It is very rare but associated with high morbidity and mortality. Most patients are female and have platelet-specific allo-antibodies exclusively found in previously pregnant women and cause platelet destruction of both transfused as well as the autologous platelets in the patients. The treatment of choice is intravenous immunoglobulin, but plasmapheresis may be necessary to remove the antibody and avoid the bleeding complications. Non-immune mediated transfusion reactions include transfusion-associated cardiovascular overload or TACO, metabolic derangements, and iron overload. TACO describes the occurrence of hydrostatic pulmonary edema after the transfusion of blood component therapy. It is not immune mediated and is associated with increased capillary permeability. It requires the evidence of acute respiratory distress within 6 hours of transfusion with features of left heart failure, including raised CVP or increased brain natriuretic peptide. It increases the length of both ICU as well as the hospital stay. Preventive measures include slowing the rate of transfusion, administering one blood product at a time, frequent assessment of vital signs, symptoms, and pulmonary status, rapid treatment of volume overload with diuretics. The metabolic derangement associated with blood transfusions include hyperkalemia, citrate toxicity, and hypothermia. As the storage time from blood product increases, the cellular components leaks potassium and metabolizes glucose into into lactate, resulting in hyperkalemia and acidosis. Packed RBCs contain over 7 milliequivalent per deciliter of potassium depending upon the storage time and can also produce consequences of hyperkalemia such as ventricular arrhythmias, sudden cardiac arrest, particularly in neonates and patients with renal insufficiency. However, with rapid infusion rates or massive transfusion of patients with liver dysfunction, citrate can accumulate in the plasma and degrades the calcium, resulting in hypocalcemia. Severe hypocalcemia can lead to muscle weakness, tetany, arrhythmias, myocardial dysfunctions, and upper coagulopathy. It can also lead to hypothermia, especially during rapid transfusion infusion of the product, previously cold or thawed blood products. Coagulation factor in activity decreases by about 10% for every 1 degree decrease in core temperature. It can be prevented by using fluid warmers. Additional preventive measures include warming the surrounding environment, surface warming, heated or humidified inspired gases, and human fluid warmers for fluid infusion. Iron overload can result with the backed RBCs can carry increasing concentration of iron as a result of hemolysis during the storage as well as the transfusion. It can accumulate in patients who require frequent transfusions for chronic anemia or hemoglobinopathies with increased mortality demonstrated for patients who receive more than 20 units of packed RBCs. And iron overload occurs when deposits occurs in the liver, heart, and endocrine system, results in the dysfunction of the particular organ system. It is not directly detrimental to the organ system. However, iron metabolism produces harmful intracellular free radicals, which in turn cause cellular dysfunction as well as organ failure. And patients often suffer from cardiomyopathy and cirrhosis. Chelation therapy is the first line of treatment. Exchange transfusion therapy decreases the iron load compared to the traditional transfusion. Thank you.